Well, thanks for the opportunity to share my alarm at the the shortage of rural surgeons in America. So I want to introduce you to George and Chicky Watkins. They're my neighbors. This picture was taken just a couple weeks ago in their backyard, but 2 years ago, Chicky nearly died from septic shock from a perforated colon. And she had to undergo life-saving emergency surgery in our little hospital in Henderson, North Carolina, is where we live. She spent a couple weeks in the hospital and then several months recovering from that. But she's back to her feisty self, and if you knew Chicky, you'd know exactly what I mean. What makes Chicky's story, what makes Chicky's story most important to me is not that she's my neighbor and good friends of the family, or that this was done in our local hospital and that her surgeon is a really good friend of mine that I actually went to medical school with. But what's really important to me is that Chicky's success story is becoming increasingly more difficult to achieve in smaller communities and rural areas because we have a significant shortage of rural surgeons. And it's a problem that's going to last for at least a generation or two until we get it under control. Now, full disclosure, I got a dog in this fight. I am a general surgeon. We have been described as the Marines of the healthcare system, affectionately, I'm sure. I'm also an advocate for small town quality healthcare, just like what I grew up with and what I've been involved in professionally. I come by it honestly. My grandfather, among other things, was a Norman Rockwell type country general practitioner who practiced 50 years in the town he was born in and lived and raised in. My father, my uncle, and my sister are all obstetricians. They all grew up in small towns and actually worked in small towns. I've had a fairly colorful career, it's been described to me. The first 12 years, I was actually a country general surgeon, first in northern Idaho, and then the last part of that was in rural North Carolina. I then transitioned and became a trauma surgeon in an urban environment where I was teaching residents. But you know, that was really a lot of fun too, but I really missed the rural setting. So the last 4 years, I've been working for LifePoint Health. Now, they're a giant corporation, publicly traded. They own and operate 70 hospitals across the United States. Most of them are in small communities and rural settings. Their mission statement is making communities healthier, and one of their main tenets is keeping care close to home, and that's why I took this job and why I'm really interested in these guys. They hired me to go out and hire and create a group of seasoned, experienced general and trauma surgeons. And our mission, we call ourselves a surgical special forces team. And our mission was to go into all these hospitals and help the doctors in the hospitals when they needed it. In other words, if they had a shortage or there's a problem. So as a result of this really cool job, I've had the opportunity to operate in at least 25 hospitals in the United States, and I keep adding more and more each year. In addition, I've done some medical mission work and operated in the third world in Madagascar and Kenya and Nicaragua. And as a result of this kind of broad experience I have, I really have a lot of tools to do what I do in my job, which is to really ensure high quality surgical care in smaller communities and rural hospitals. Now, it goes without saying, I think, that healthcare has got some problems in America. And you know, the news is full of it. You can't get away from it. And it just seems like every time you turn around, somebody's either criticizing or wanting a piece of that $3.4 trillion healthcare pie, which represents 18% of our GNP. Now, the current debate that we see on CNN and everywhere is really framed as an actuarial math problem. You know, how are we going to pay for health care for all of our citizens? And I'm going to suggest that it's way more complicated than that. We've had decades of perverted and misaligned incentives in our system. And I'm going to also suggest that the biggest problem we have in healthcare is actually taking care of patients. And that is way more complicated than just trying to figure out at the end of the month how much money out of your paycheck is going to go to pay for your insurance premiums. So I'm just going to talk about one of those problems today. That's all we really have time for. I'm going to concentrate on the shortage of general surgeons in rural communities, and why it's a big deal, because it's going to really affect how we can optimally take care of patients in these settings, and whether or not even these hospitals are going to be able to stay open. And it's a problem, and it's going to take at least a generation to fix, if we can even get there. So rural communities are really at risk for the perturbations in these healthcare changes. Now, some more full disclosure, that's actually my son's car, and he drove it across our country on a big trip. But rural populations, when compared to urban populations, they tend to be older or under 18, poor, uninsured, more likely to be disabled or chronically ill. And you know, rural communities have problems with financial issues, and they have unemployment and other issues, and they often are underrepresented in our legislatures. And there's plenty of evidence that rural hospitals are already taking it on the chin. In the last 10 years, 200 maternity wards have closed in rural areas nationwide, leaving 54% of all rural counties without any hospital-based obstetrics. In that same time frame, 60 hospitals have closed in 22 states, rural hospitals, and it's estimated that about 700 more in 42 states are vulnerable or at risk for closure. Rural hospitals are really important to their communities, and some of you already know this, but you know, they serve as the organizational core, not just for healthcare, but for social services. They are often the largest employer, and one thing is for certain: if you don't have a decent hospital, or if you lose your hospital, you're never going to recruit any more business to your community, or you're going to have trouble recruiting businesses to your community. And the other thing is for sure is that if these rural hospitals can't offer key specialty care, they're not going to survive. And we know about what these important specialties are, and general surgery is one of the well-known specialties that keeps these rural hospitals open. Now, there's plenty of historical precedence that supports this. You know, every rural hospital for 30 or 40 years has had a surgeon, and they did all the surgical work. And surgeons, you know, well-trained surgeons can do almost every single general surgery case in any hospital. You don't need helicopters and, you know, TV screens and all that kind of stuff to do most life-saving surgery. And most of the guys in my group know that for a fact, because we've operated in third world, done major operations in a tent. So we know general surgery is important. You know, we're on the front line of medical emergencies and surgical emergencies, and there's some studies that have come out comparing rural surgeons to urban surgeons and their caseloads. And they know that rural surgeons do a wider variety of cases when compared to urban surgeons. And they do a higher percentage of cases in those hospitals. Now, this is pretty, you can explain it. If you're the only guy in town, then you got to do what walks in the door, and you're going to. So rural surgeons need a bigger, a broader skill set than their urban patients. There's also some intriguing studies that have come out that have shown that rural surgery patients actually do better than the urban patients. They have shorter hospital stays, less morbidity, surgical complications, less mortality, and their costs are cheaper. Now, this doesn't mean that rural surgeons are better than urban surgeons necessarily. It probably means that rural surgeons are choosing their patients correctly and probably sending the more complex patients down the line. There's some more other intriguing studies that are out there. A study out of Maryland looked at nearly 500,000 patients that had emergency surgery either in a smaller community or a big city, urban, tertiary hospital. And what they found was that the cost of care in the tertiary centers were significantly higher than the community hospitals. And if they had to be admitted into the ICU, then their costs were twice as much. And these studies just looked at medical costs. It didn't even go into the inconvenience of care or the opportunity costs that people from smaller communities had to incur when they traveled to a bigger community. And then there's one more study I just want to mention. We already have a shortage of rural surgeons. A study just came out of a teaching institution in Maine when they looked at transfers of surgery patients from rural communities. And what they were surprised to find was that 50% of the patients that were transferred to their institution came because there wasn't a surgeon at that transferring hospital to take care of them when they needed it. There have been unintended consequences that have led to this shortage of surgeons. I trained under the old surgery paradigm back in 1990. I don't know if y'all heard anything about that, but the best people could say about it was that it was inhumane, and the worst is that it was dangerous. I don't really remember that, but we were trained in a way to maximize output with minimal resources. And just for an example, when I finished my residency, I went to work as a rural surgeon. And I worked pretty much every day, every other weekend, every other night for about 12 years. And it didn't even seem odd. I mean, that's just what we did. And in fact, it was actually written in the hospital bylaws that that's what our schedule and what we were required to do. Well, times have certainly changed. In 2003, the committee that governs residency education, so all the residents, imposed mandatory maximum work hours. Whether this was good or bad is being vigorously debated now because the safety and quality data is really inconclusive. But one thing is absolutely certain. That change has changed the way surgeons think about their job. When, if you look at millennial resident graduates that are under the age of 35, they are being projected to work 13% fewer hours than their older cohorts, which comes out to be 2 or 3 days per month. And understandably, the new grads want a more balanced work-life balance, a more favorable work-life balance. They want to work fewer hours, have more family time, and not be on call as much. And I'll tell you, the older surgeons have heard this and they agree, and we all want better work-life balance as well. But what's happened is the current workforce is refusing to adhere to the old delivery of care model. And delivery systems, hospitals, are having a hard time coming up with viable plans to field a team on a regular basis. So the numbers are out, and we don't just have unintended consequences, we actually have a shortage. So if you look at the numbers of surgeons between the ages of 55 and 75, which unfortunately is my age cohort, make up right at about 37% of all active surgeons. Now these are, we should be thinking about retiring or maybe even be retired at that age doing surgery. Rural surgeons are older than the mean in every category, including general surgeons. General surgeons that are retiring in rural areas are not being replaced, and we already have a geographic maldistribution of the workforce. And then if you look at demand, which is really driving this is all demographics. It's all about the baby boomers, surprise, right? So the baby boomers have come of age. They're now hitting the age of 65. And in the next 10 years, that population is going to increase by at least 40 to 50%. And you know who uses healthcare? It's the older people. So what we have now is a perfect storm. We have decreasing volume of care that we can give, and we have a surge in demand. So we have an aging physician population. In 2016, more physicians retired than went into practice. It's the first time that's happened. We have fewer surgeons working fewer hours, when it really takes more surgeons to do the same amount of work, and we have more work to do. So where are the surgeons? Now, anybody who's looked at demographics knew this should have been coming, and some people did, but I mean, it's as if things really haven't changed until it's a crisis point, and that's common in many portions of healthcare. Why don't we just train more surgeons? I mean, that's, you know, just train more. Well, it's not quite that simple. It's extremely expensive, it's complicated. You know, Americans don't really like mediocre surgeons. So you got to be thoughtful about it. They actually have started, they've been trying to train more surgeons. So for the past 10 years, they've made a conscious effort to increase the number of surgery residents, and they have actually increased it by 100 in the last 10 years. So right now, approximately 1,100 chief residents graduate every year. It takes a minimum of 5 years to finish a general surgery residency, a minimum. Most people take longer. And then it gets really complicated. Of that 1,100 people that finish, 90% of them go on for subspecialty training. But when it's all said and done, you end up with fewer than 200 general surgeons who are coming out to join, fewer than 200 chief residents who come out to join the pool of general surgeons who are out taking care of hospital emergencies and doing all the elective surgery that has to be done. And then when you finish, you still got to go do the job. And general surgery is still intense, it's stressful, it's physically and mentally challenging. Remember, we're the Marines, right? It's getting harder to get the younger surgeons to sign up. You still need a broader skill set in the rural communities, which is intimidating to the younger surgeons. The rural markets are smaller and have a harder time supporting a large number of surgeons to share the burden of call. So the fewer surgeons you have, the worse the lifestyle. We have an increasingly negative feedback loop that's at play in rural communities, and it's really making it hard for the hospitals to field a team to cover the entire process. Now, Congress has noticed. In June of this year, they introduced a bill, both the House and the Senate. It's the same bill, where they acknowledge that there is a shortage of general surgeons. And this bill suggests that we develop a methodology to study it and decide which populations are going to be at risk. So I'd submit it's probably it's a little too little and a little too late to help us in the near future anyway. So I've told you what's bad, and now I'm going to kind of tell you what the bridge is at LifePoint. So what we're trying to do to mitigate these shortages is develop strategies to help the surgeons in the community. And my group, OmniPoint Surgery, was the first step that LifePoint went. So they hired me in late 2013 to put this group together. And this is part of our guys. And they don't much look like a special forces team. But they're really, really talented, good guys. And so what we do is we go into these communities and we add just help, just a body first off, but we have intellectual expertise and resources and leadership skills. And we've had very significant success in the short term. But what we found is when we left, you give that a little bit of time, then these hospitals would kind of fall back in their same pattern where things were kind of falling off the rack again. So we had to come up with another strategy. So about 2 years ago, we started working on developing, or about 3 years ago, developing structured acute care surgery programs. Now, if you know anything about the business, we've been putting these in larger institutions that have high volumes for several years now, but there really has been no experience in the smaller hospitals. So we've been putting these in where you actually develop a team approach for taking care of acutely ill surgical patients in the hospital. And you do it by having a shift approach to hospital care. And what that does is it allows surgeons to compartmentalize their workload. They can avoid long stretches of call, but the other important part is it separates their elective practice from their emergent care. Now, it's really stressful when you're running a clinic, seeing patients, and they call you to the emergency room. or to the floor for some kind of a consult. And it happens all the time. It's incredibly disruptive. It inconveniences the patients. It's stressful. The surgeons have a hard time getting back on track. So these programs separate all that, and it makes the surgeons' lives more predictable, less stress, better lifestyle. And in fact, we have a program that's been in fact for about 18 months just down the road at Wilson Regional Medical Center, and it's been extremely effective by all accounts. And it's allowed them to recruit younger surgeons into their practice in the last year and a half, which they were unable to do before this program was put into effect. Now, our other strategies aren't as far down the line, and they're kind of longer plays. We are partnering with university residency programs because we know there are general surgeon residents out there who want to work in rural communities, and we're trying to identify them, give the universities some resources. We want to identify them first, support them, and then recruit them into our hospitals before somebody else talks them out of it, which is really what's going on in a lot of these training programs. We only have a few programs, and it's on our list to get done in the next year or so, and longer. The last two really are just kind of ideas that we hadn't gotten much traction with my leadership, probably because they really cost a lot of money. But you know, robotic surgery and advanced laparoscopic surgery are kind of the next thing. And again, there's almost no general surgery cases that we can't do in a rural hospital. All you got to do, if you got a power source, you can plug up your computers and you can do this robotic surgery. It's just incredibly expensive. I mean, each robot costs $1 million. But we know we're not going to be able to recruit the younger generation of highly technically trained robotic surgeons unless we get this. But there's no reason we couldn't get it. So that's next on my agenda that we're working with. And then there's got to be some government intervention here. There is some precedence with, you know, loan repayment for rural commitment, and then the J-1 visa program, which is really kind of off the agenda at this point with this current administration. But there's really nothing going on in this field right now, and there's not going to be until the electorate really starts to complain. So just to review the takeaways, there is a shortage of surgeons in rural America. And in 10 years, it's going to be all over America except for the nicest cities. It's a big deal. It's going to adversely affect all the constituents. There are some practical short-term solutions, but the long-term is going to be a problem. You can help support your local hospital when it's possible. You can tell your friends. You can contact your elected officials. But this is what it's about. Thanks.